Kali bagi kategori pentaksiran alternatif, kami jemput finalis daripada Universiti Melaya dengan tajuknya The Use of Entrustable Professional Activities as an Alternative Assessment Tool for Entry into Pediatrics Postgrad Training Program in Malaysia. Dipersilakan.
Terima kasih. Selamat petang to the juries and to all my rakan-rakan. The title is very long, but I want to focus on the word entrustable professional activities as an alternative assessment tool for a postgraduate training program in Malaysia. And I'm not alone because this is a working group consisting from members from the Ministry of Health and the Ministry of Education. From the universities, include all the universities that are embarking on postgraduate medical education. So you can see they're from UITM, UPM, USM, UKM, and UM. Now, I think most of you are aware that we produce about 5,000 new doctors every year. When they graduate, the young doctors are very happy because they're going to go to a new job. They call housemen, house officers. The problem now is because of 5,000 young doctors coming into the system, there are no jobs for them. So there are no placement for house officers. And you can see from the media, they are actually working as waiters, Grab drivers, and so on. And the problem is this is compounded by the huge number that are being produced with no jobs. Not only on that, they are also trying to get into postgraduate medical training in Malaysia. So you can see that currently there are two pathways that are existing in Malaysia. First one is you join the Masters of Medicine program, or in short MMed, which is a 4-year structure program administered by our local 4 public universities, usually sponsored by the Public Health Division. And of course there is the self-study pathway where they try to attempt to sit for professional exams, for example Royal College of Medicine or Pediatrics from the UK and so on, and they will continue the service at Ministry of Health hospitals. The main thing is to enter this kind of program, this national program. All these young doctors now need to join this program by testing themselves through a knowledge-based assessment, and that is usually in the form of MCQs, multiple choice questions. And the second issue is professionalism, and this is a medical course which emphasizes on professionalism, such as values, attitudes, and behavior are not assessed at all in any of the current mode of assessment tool that we are using. This is a big problem because we want to train doctors who are safe, who are kind, who are caring. With the huge number of doctors being produced, we are going to see the dilemma whereby doctors are practicing in an unsafe manner, they are rude to patients, and they are not knowledgeable enough to take care of our people in the kampong, in the rural areas. So we are going to transform this postgraduate medical education from a time-based rote learning process to a competency-based problem-solving medical education. And of course, the overriding consideration is patient safety standards and try to address the lack of communication skills among our students. We are trying to change this by making our doctors safer and more caring. And because of this, there's an urgent need to assess professionalism and to help to break this bottleneck of large number of employed doctors, because they all had to wait to sit for this MCQ exam, entrance exam, which happens once or twice a year. Why not do it throughout the whole year? And you can assess them continuously throughout the process. So, based on this, the working group has embarked on a literature search, a worldwide review on all current programs, and we have actually looked at this competency-based formative assessment tool called Entrustable Professional Activities. Now, we also call it EPAs. Now, basically, EPA and its approach to assessment, which simulates the process of entrustment similar to someone who is supervising the trainees and allow them to perform certain tasks at the same time assessing their knowledge, skills, attitude, and behavior. So you can see that at the working place, you can see how they perform, whether they're safe doctors and whether they are professional in their behavior. And this behavior could be in the form of positive behavior, negative, or negative passive traits. So, and on this basis of these new EPAs, the trainees are selected for further postgraduate training. For those who are not familiar, EPAs have been around for quite some time, 20 years, usually used in North America. Singapore started to look at it recently for undergraduate medical training program, and it has been validated. Most of you will be familiar with Miller's pyramid of assessing clinical competence. Now, for those who are not sure, this is basically a pyramid, consists of knowledge, skills, and attitudes. And as the trainee go from a novice to an expert, they go through the process of learning, of knowing, knows how, and then they shows how, and they actually do the procedure. For example, perform surgery and so on. At this lower level, a lot of it is cognitive behavior. At a higher level, where you need to talk to patients, you got to care for people, it's about behavioral issues that are now more important than just a cognition. Now, what is the project approach? We actually undertake extensive consultations with all stakeholders and trainees throughout Malaysia, including Sabah and Sarawak. And we actually look at what are the needs of the people in the rural areas. And because there are no prior publications or any kind of literature on this use of EPA in postgraduate medical education, this is the first time in the world we are doing it, and with the help of all the stakeholders in Malaysia. And we also align it to all the learning outcome domains to MQA requirements so that we do not deviate from the original aim. And we use some of the most common conditions seen in Malaysian health system, for example, a baby with jaundice, asthma, gastro, fits immunization, how to take consent for blood transfusion, and how to learn how to take blood. We call it venipuncture. The rubric for assessment for these two examples are going to be shown in a short while. And these are selected on the basis where it can be performed even in a small hospital using a face-to-face case-based discussion. This is a flow chart of how the assessments are done. So you can see that right at the top, the consultants will discuss on all the needs, and then they will develop the cases, the 7 cases, so it's fairly easy and simple to do in all the villages and health centers. There are no big videos, there's no need for big equipment, just simple face-to-face meeting like this one here. And the trainees will meet their supervisors, set a date and time 1 week before, and this EPA session will be undertaken by the senior doctors in the district hospital, for example, and then there'll be feedback from the students, trainees, and also from the assessors themselves on the performance. Now, this is an example of a 2-page simple kind of assessment tool. So the first site is basically I will show a great detail about knowledge, skills, and attitudes and values. And they are the behavior, the positive, negative, and negative passive behavior. This is by the assessors. This other page here is the feedback from the trainees, the students themselves, so they are 100% involved, and also feedback from the assessors themselves. This is a close-up look on the page, and this is the one that is the crux of what EPA is all about. If you look at this particular worksheet, it's about jaundice, a baby who is yellow. And we assess knowledge, and this is what we call in medical terms standard setting. That means you set a level of standard that is required at their level, and if they manage to get through all this, then there's a pass to them. So for example, there's a knowledge-wise, like the causes of jaundice, how to investigate and test them. The skills, like how do you identify the severity, how do you take blood. And the attitudes is like, do you encourage the mother to continue breastfeeding, and what empathy is the candidate showing. The positive values, behavior, for example, able to have a logical approach to identify the problem. We also look at negative behavior, for example, giving wrong advice. And the negative passive is like ignoring concerns or distress, being rude, and not failing to educate parents accordingly. All right, and this is another example on blood transfusion. Same thing, we all set the standards. So it is standardized across all hospitals, whether you practice. So all the candidates feel that they are treated fairly and equal level playing ground. And this is where it happens in the district hospitals, small places, it can happen. So there's no need for these candidates to come to the town centers, the KL, for example, to sit for exams using MCQs. They're all using this case-based face-to-face EPAs. And what we have done is we took the feedback from all the candidates, the trainees, and we look at how much time is required. This is very important. Everyone complained that it would take too much time, but it's only 25 minutes. And it takes into account all the face-to-face interaction. And overall, the assessors felt that EPA were not disruptive, and this is very important because if the consultants felt that they're not disruptive, it's very useful, then it's going to be a buy-in from all the specialists. We also look at the students' feedback. 78% felt that they have full confidence in doing these tasks. And of course, there's also support from both student assessing in using EPAs in future programs. So what is the project impact? The first thing that you can see here is that we are now creating new learning space. There's no need to come to the universities all the time. They can do it in any health facilities in the Ministry of Health hospital. Because they are now studying and learning very hard to do the EPAs, it translates into better health care for patients in the place where they work. It's also cost beneficial because now we have done some health economics modeling. It's much more cost effective, so they can train larger number of specialists in a shorter time. But most important and interesting is that we feel that it can be used in all medical disciplines, including non-medical professional courses, because the principles are the same. So ladies and gentlemen, thank you very much for your time. Appreciate if you have any questions. Thank you.
Thank you. Okay, thank you, Prof. Talking about the rubrics, how did you develop the rubrics? I mean, what is the theoretical background that you followed to come out with these rubrics?
Okay, so we carry on from our usual problem-based learning system, whereby if you are familiar with it, there are certain knowledge they are supposed to acquire over a period of time during the undergraduate. So this is the system where you carry forward into their next phase of life. That means they're going to embark into postgraduate learning program. So using the existing undergraduate curriculum, so there's nothing new in there. So, but you carry forward because you want them to remember what they have learned. And that is a very important thing. So the rubric system, basically, if you have seen those breakdowns, the standard setting, is all very basic medical knowledge. Unfortunately, a lot of them, if they have been poorly trained, they would not have those kind of knowledge. So we use a very simplistic way, but it's very effective because once you trial it, we know that it works.
I may have missed earlier. Currently, the practice to take them into this postgraduate, what kind of assessment?
The current system is very old colonial British system. That means they either sit for a UK exam, but they pay a large amount of money, pounds for example, to sit for the exam. They go to the UK and sit for the exam. The high failure rate, 20%. Their focus is on diseases found in UK, not Malaysian. All right? But because this is a legacy problem, we have allowed it to happen. But in the last 20 years, we have started our own masters. We call it the MET program. So there are two pathways. Now, the first pathway, the students pay for their own exam. The master's pathway, the government pays for them because they will be bonded, right? But it's a structured program, so there is a 4 years involved. For the overseas program, they can sit for exam anytime. It's actually not an exit exam like a master's program. It's actually an entrance exam. But due to a legacy problem, entrance exam was also accepted as the final exit, similar to exit exam, which we feel is very unfair because it is not equivalent. So with this new curriculum, we are now leveling the field so that if you still wish to sit for this so-called more prestigious British exam, you still have to go through a 4-year program. But before you do that, you need to enter to assessment using EPAs to see whether you're suitable or not. So that is the current system that we are using. So the EPA changes the level playing field by making sure that all candidates, regardless of where they are working, had equal chance to enter into postgraduate program. And to making sure that the basic concept is about patient safety and of having a caring and empathetic attitude.
And the rationale of doing this is also because there's a lot of there's a lot of young doctors who don't get housemanship and
Correct.
They are proceeding to the postgraduate.
That's right. So this is to facilitate the process, to make it faster, a more open system, so that if you work in Perlis or Pahang, you can still sit for this exam. And because it's an open system, you study where you come from, where you're staying, and you just go and sit for the exam at the end of the day. There's no need for them to come to KL and transfer their families and so on, which is a big hurdle for young families.
And the people who will administer them will be doctors.
Senior
whoever.
doctors who are all working in wherever they're working.
Okay.
All right, and this has all been agreed by both ministries, and all of them have agreed to this system.
And sort of like this has been approved to
This
go.
is, in principle, has already been approved by the Ministry of Health.
Okay, right.
Okay, how you manage the process of observe the doctor to make it genuine? Is it from video or doctor?
Okay. Medical training is about the human touch. We don't rely a lot on technology, online learning. It's good for basic skills. But when it comes to higher professional behavior, right? For example, learning to listen to people, showing a caring attitude, going the extra mile to help people, is always very labor intensive in the sense that it has to be a personal interaction. It's always a kind of face-to-face, case-based discussion, because they could never learn from textbooks, online anything, online information, if they have no mentors that they can look at, if there are no leaders they can go through when they've encountered problems, when they see a patient which they have no experience with. So it's all about apprenticeship and mentorship in postgraduate medical training.
Based on this, I mean, maybe the question was about because we want to measure the patients of, just now you say, are they patient with the patient? Are they polite? So this kind of behaviors can be also like, first, how do we assess this? Is it by observation?
Yes.
And the other thing is, it can be, I can pretend. Like if my supervisor in front of me and a patient, I can look as nice as I can be while I'm not actually nice. So
Yeah.
how do you?
It's well known, very intelligent people, like, I wouldn't say doctors, but intelligent can fake certain behaviors. But you can't fake it every day and all the time. So what you are doing here is, because we feel that 7 cases are actually a good representation, and if you're going to fake it, it's going to be very hard, because some of these attitudes, behaviors, for example, is very obvious, because we're going to observe them talking to the parents, for example, of a child who is unwell. It's for us experienced doctors, we can see that you are in a rushing mode, you are not taking your time to sit down and talk to people, you have been very condescending in your answer, giving a short answer to questions that need some explanation. So that's what I'm saying. This is all about mentorship, where you can assess, and it's very hard to assess professionalism, professional behavior like that. And I suspect a lot of times it's not done in any part of the world, because it takes so much effort, and you really need people who are dedicated in trying to do this situation, to redress this situation.
Okay, based on this, did you assess the assessment after you have done the assessment for certain number of candidates,
Yes.
and then did you look into the results of the assessment and how is it reflected?
So you can see that some of the graphs that we had, these are actually based on statistical analysis that were done through a big, fairly large sample size. It's also qualitative assessment, so a lot of them are feedbacks using comments. So we have actually collected a lot of this qualitative evidence of whether it's good, whether it's suitable or acceptable. You can see that not all the doctors, the junior doctors, are happy with it, because it means that they have to study. But it also meant that if you did not have a good attitude, you will not like it, because you feel that I do not want to study like this because I have passed all my exams. But the fact is, medical education is a continuous medical education. You cannot stop learning. If you're the type who stop learning, you cannot be a good doctor. So you will weed this one out because you are not suitable to be trained as a specialist in Malaysia.
When is this expected to take off?
For the pediatrics program, we are actually the pioneer. This is actually under a big umbrella of programs. So you can see that there's a steering committee and we have foreign experts. There is now a revamp of all the 22 postgraduate medical training program throughout Malaysia. It's going to be standardized to one curriculum for every discipline. And all of them can sit for either the master's program or you have an overseas program, you can choose to sit. So examination is not an issue. It's about the curriculum and assessment of your professional behavior that we want to emphasize on. And it's going to start next year, 2020.
Sorry, again, going back to the assessor, who is the supervisor, how do we ensure that, of course they are professional, but like we educators, when we do the assessment also, because this is more on behavioral
Yes.
assessment besides knowledge.
Yes.
How do we ensure that there is no personal influence on that?
Yes.
You know, because it's not based on knowledge, of course. It could be right or wrong, but
Yeah.
in behavior, if we want, three of us
Mm.
might have different opinion on that behavior.
Yes.
So how do you
So
ensure
the
that?
first thing that, and we realized this is the problem, it's a very, very pertinent issue that was the first thing that was raised. Is there going to be kind of biasness, someone who likes you very much will give you a high marks and so on. So the issue here is twofold. So we need to train the trainers. So we already embarked on a mini curriculum for train the trainers. So they also train the students. There's also train the trainers, because teachers need to be trained how to train students. Very often we learned by looking at one and seeing one, and then we do the same thing. That's not acceptable anymore. So there is at least a course that's been developed where we train the trainers. The second thing is that because it's not one person who's assessing, there will be like at least 3 to 4 specialists or doctors, senior doctors assessing. That will also reduce the probability of biasness, because it will be very patently obvious if someone give 100%, whereas 3 other doctors say he's only 50%.
Thank you very much.
Thank you so much.